Thanks for this opportunity to present antithrombotic therapy in patients with PAD for CVI 2020. It's really an honor and a pleasure to be able to present this, and I appreciate the opportunity to do so. These are my disclosures, and it's important to recognize that I have disclosures from some pharmaceutical companies that provide antithrombotic and antiplatelet research and therapy to patients with vascular disease. Let's start with a case. This is an 82-year-old female with hypertension and diabetes and severe leg pain in her right leg. She was walking her dog when she hit her right leg on the door. She developed an ulcer, and it was actually in the forefoot. You perform a popliteal and TP trunk atherectomy. As you can see in the angiogram here, she has some disease, and an angioplasty. And so the question is, after you revascularize a patient, often we're very good at thinking about how to do that. How do you manage your patients? In fact, our goal with patients with PAD is often to improve their symptoms or preserve their limb and reduce their cardiovascular risk. So what's the best way to do that? What would you do to treat this patient? Would you treat this patient with aspirin and clopidogrel, rivaroxaban 2.5 milligrams plus aspirin, or clopidogrel 75 milligrams? Here's some data that we think is important to think about. Pathophysiologically, we've spent a lot of time thinking about the platelet, the center of this diagram. We now know that many of our patients with more antiplatelet therapy may not do as well as we thought. And now with factor X inhibition, rivaroxaban and the drugs like it, plus aspirin and dual pathway inhibition, we may help with both the limbs, the heart, and the brain. In fact, here is the Capri trial, which studied clopidogrel and aspirin over 20 years ago now for the reduction in MI, ischemic stroke, or vascular death in a broad group of patients with vascular disease. And the relative risk reduction was 8.7%, as you can see, with an absolute risk reduction of about 0.5%. PAD patients might have done a bit better here, but this wasn't really a substantial improvement with clopidogrel, a slight improvement. Important, but slight. It's also important to recognize that dual antiplatelet therapy in the Charisma trial, aspirin and clopidogrel did not beat aspirin alone. I was involved with a group of investigators where we did the Euclid study, which you can see on this slide. There, ticagrelor 90 milligrams BID was studied against clopidogrel in over 14,000 patients with PAD, with the primary endpoint being cardiovascular death, MI, or ischemic stroke. And we were surprised to find at the end of this trial that both ticagrelor and clopidogrel had almost the identical event rate for CV death, MI, and ischemic stroke of 12.5%. No significant reduction. So, what would you do to treat this patient? Aspirin? Well, chronic therapy it's the most common agent, and it's slightly worse than clopidogrel in the Capri trial. Aspirin and clopidogrel? Well, this is dual antiplatelet therapy, as I stated in the Charisma trial, did not beat aspirin. Rivaroxaban 2.5 milligrams BID plus aspirin? The Compass trial has shown this benefit in chronic PAD, and we wonder about post-revascularization. I'm going to show you some of that data here today. Clopidogrel 75 milligrams? Well, this was slightly better than aspirin in the Capri trial, similar to ticagrelor in the Euclid trial. This data, I think, is important. It shows the background of how we should be thinking about our vascular patients. You can see that there's a stable phase here with major adverse limbs and increase in acute limb ischemia, and Compass has studied this. But what about the acute post-revascularization phase, where the patients may have post-revascularization ALI, amputation, or other events? So the objective of the Voyager PAD trial, another trial I was involved with a group of investigators from around the world, was to investigate in patients undergoing acute lower extremity revascularization for ischemic symptoms to see if 2.5 milligrams twice a day of rivaroxaban, twice daily, added to aspirin, reduced the risk of major adverse limb and cardiovascular events compared to aspirin alone. This was the same dose that was studied in Compass, and the same dose that had been studied in Atlas before. And of course to test the safety of that dose also. So here was the trial design, over 6,500 patients with lower extremity PAD undergoing acute peripheral revascularization for ischemia, randomized to rivaroxaban 2.5 milligrams twice daily or placebo on top of aspirin, and patients were stratified by whether they got endovascular or surgical revascularization. Clopidogrel was allowed at investigator discretion for up to 6 months. Most of the patients got it for about 30 days. And the primary endpoint was CV death, MI, ischemic stroke, acute limb ischemia, and major vascular amputation. The Primary safety endpoint was TIMI major bleeding. These are the findings of Voyager PAD. First, importantly, out over 3 years, post-revascularization, these hard vascular events occurred in 1 in 5 patients, or about 19.9%. Rivaroxaban significantly reduced that event rate to 17.3% with a hazard ratio of 0.85, and this was significant. When you looked at the early time point at 6 months, there was an absolute risk reduction of 1.5%, at 1 year 2%, at 3 years 2.6%, with a number needed to treat of 39. Regarding safety, numerically you can see that there was more TIMI major bleeding, 62 versus 44, but this was not significant with a hazard ratio of 1.43 but a p-value of 0.069. Again, more numeric bleeds in TIMI major, but very similar, if not less, ICH bleeds, similar fatal bleeds, and combined bleeds were very similar. The only significant different bleeding rate was ISTH major. When you looked at risk and benefit, you reduced 181 primary efficacy endpoints for 29 safety events. So really a favorable risk-benefit ratio. So in summary, in patients with PAD undergoing lower extremity revascularization for ischemic symptoms, a regimen of rivaroxaban 2.5 milligrams twice daily added to aspirin reduced the composite of acute limb ischemia, major amputation of vascular etiology, myocardial infarction, ischemic stroke, or cardiovascular death. The benefits were apparent early and continued to accrue over time, and they were consistent across all major subgroups, including CLTI patients or CLI patients, those with endovascular and surgical revascularization. In summary, this reduced also the unplanned recurrent peripheral revascularizations, and this all happened with some increase in ISTH major bleeding that did result in higher rates of the principal safety outcome, TIMI major bleeding, although this difference was not statistically significant. So, in conclusion, at least 1 in 5 patients that we do peripheral revascularization to will have one of these events, which include ALI, major amputation, MI, ischemic stroke, or cardiovascular death. 2.5 milligrams twice daily of rivaroxaban with aspirin significantly reduced this event rate. These data do complement COMPASS now and demonstrate the efficacy both in acute revascularization in the setting of PAD and chronic long-term secondary prevention with PAD-CAD for 2.5 milligrams of rivaroxaban. So going back to my first question, how would I treat this patient? I believe now rivaroxaban 2.5 milligrams BID plus aspirin should be the bedrock of most of your post-revascularization therapy. I did not show you the clopidogrel data, but I can show you that clopidogrel, which was not randomized but was pre-stratified and discussed as a preordained sort of way we were going to look at the events afterwards, pre-specified subgroup. Clopidogrel did not significantly modify the effect of rivaroxaban, and the only thing it did was potentially increase bleeding a little bit. Thank you, and I appreciate the opportunity to present these findings.